I'm David Goldsmith, and I am very pleased with Kevin Hedges to welcome everyone here to the Whwb Global Workplace Silica Exposure and Health Risk webinar. Kevin and I are past presidents of Whwb-Us and Whwb International. I don't know what that means, but we are. So we are delighted that everyone's here. And I just want to very briefly share with you some two gentlemen whose work really has inspired me, Corbin McDonald on the right and Umberto Safiati on the left. And both men each had a foot on both sides of the Atlantic, and that inspires us to think about silica issues on a global basis. And for those young people who don't know who these two folks are, I would strongly recommend that you type their names into a Google search or go on to PubMed and read some of their work. Their work is outstanding, both in pathology and in epidemiology and occupational medicine. So I also want to take my hats off to two women leaders of WHWB. You've gotten a chance to know them if you've been on the line, and especially both of them have been past presidents of WHWB, and I am involved in this organization because the two of them stirred me up and urged me on, and I'm very grateful personally for this. So just some very quick go around to thank everybody. The people you're going to hear in the next couple of hours: Noemi Hall, Frank Hurl, Dion Williams, I believe that's Shelley C., Victoria Arundel, Rodney Ehrlich, Ryan Hoy, Sheikh Khalif, Alec Farker, Melanie Ng, and Bob Harrison. Each pair is going to speak for approximately 15 minutes, and we will have time for questions, but I want people to use the Zoom and in the chat box to send questions. And this is something that that we intend to use to ask questions when we get around to the roundtable. I do want to tell everybody that we're going to be pretty strict with time, and but that this program is going to be on the WHWB-Us website, and here is the URL for that. And I mentioned the session is going to be taped, and I'd really like to thank Dr. Kevin Hedges. Apologize, Kevin. Oh boy, did I misspell your name. This is terrible. For helping steer the webinar, and he's got an incredible amount of contacts in Australia and in Asia, and I am extremely grateful for his help. So really briefly, this is what we're going to do. We're going to have a short intro that we're in the middle of, and Alec Farker is going to tell us a little bit about asbestos, and then we'll jump right into the program with Melanie Ng and Dion Williams. And we're going to talk about countertops, and then we're going to talk about silicosis with myself and Rodney Ehrlich from South Africa. And that will be followed after a break with Sheikh Ali from Monash, Noemi Hall from the NIOSH in Morgantown, West Virginia. We'll talk about silica and cancer risk with Shelley C. from China. And then lastly, something about silica dust policies led by Victoria Arundel and Frank Hurl, and then the roundtable, which I mentioned before, will be the end of the session. And we hope, as I say, to be on time. So I want to turn the session over to Kevin and let him say a few words, and then we'll go to Alec.
The first thing I want to do is just reach out to my supervisor, Dr. Sue Reed. I just see that she's joined, and I'll always be grateful to you, Sue, just for, your supervision with my own PhD. I just thought I'd put that out there first. The other thing is, so Mary O'Reilly's the president of Workplace Health Without Borders International, and Tuan is the president of the US branch. This is a combined US international webinar, but I also just want to acknowledge the UK branch and Dorothy Cook and Peter Baldwin. They've also developed a silica awareness training, which we'll put in the chat box as well. And I also just want to reach out to everybody on this call. We're really looking for people to help us. And I've been asked just to put an expression to you to, if you want to be part of our outreach and communications committee, just make a note in the chat box and we'll follow up as well. We're also reinvigorating our health group workers providers group, and Dr. Claire Wood actually was the founder of that, and we're trying to reinvigorate that as well. That's basically it from me. Thanks everyone for joining. It's really blowing me away when I look at the caliber of the speakers here. I think we're going to get a lot out of this. So, and back to you, David, and then I guess to Alec.
Go ahead, Alec.
Hello, everyone. I'm Alec Farker. I'm a lawyer and former regulator from Ontario in Canada. And I'm just thrilled to be with the group today. I've called this a historic event, and I really believe that it is. It's so deep, it's so broad, it's so well-informed and powerful. So I'm here to give a little bit of a brief report on Workplace Health Without Borders International's work, along with our US branch, our UK branch, our Australian branch on asbestos. We've set up an asbestos working group. And as everyone on this call knows, there's a worldwide movement that has succeeded in getting asbestos banned in a lot of countries over the years, including Canada in 2018, after many other countries. And yet asbestos is still in active use at about 1/3 of the level it used to be. And there is a tremendous amount of legacy asbestos in many, many workplace settings, exposing workers all around the world. So we thought, let's figure out a way for Workplace Health Without Borders to mobilize our specific expertise in occupational hygiene and occupational medicine, in ventilation, in my case, in regulatory affairs, and combine those forces to focus on issues where we can really add some value. So we set up an asbestos working group last year. Our next meeting is May 17th at 8 a.m. and I'll put contact information. So if you're interested in getting involved, you'll have my email and can get in touch with me. And our focus right now is in 2 key areas. First of all, looking at best practices and guidance around the world to try to find the most effective guidance that can be used in a setting where resources may be scarce. So that's our first priority, and we're scanning the world to find the best tools and resources to accomplish that. And by the way, some of these tools and resources are relevant to silica as well as to asbestos. And secondly, to look at substitutes for asbestos, which relate to finding a way to encourage people around the world to substitute, especially for corrugated asbestos roofing. And we've already done some preliminary research, and we'll be looking for help on that. So I'll post my contact info. Anyone who wants to get involved. Our next meeting is 8 a.m. Eastern, which will be accessible to most people around the world, although requiring West Coast US to wake up at 5 in the morning, and maybe some other people quite late at night. So looking forward to meeting some more of you in our working group, and we'll take it from there. Thank you.
Thank you very much, Alec. I have the pleasure of asking these two brilliant women to kick off our program, talk about silica exposure assessments. Melanie Eng from the University of British Columbia and Dion Williams from the Occupational Safety and Health Administration here in Washington, D.C.
I'm Melanie. Hi, everybody. So I'm talking about the Silica Control Tool, which is a web tool for risk assessment and control of silica that we use in British Columbia for developing exposure control plans and risk assessment. So for some background on British Columbia and how silica is regulated here, we have substance-specific requirements for respirable crystalline silica that were implemented in 2017. So we developed the silica control tool in response to these new regulations, where basically anybody who's working with silica and might be exposed above the exposure limit needs to have a written plan of how they're going to manage silica, and they need to be able to estimate what their exposure level will be. So the silica control tool is designed to help employers with that. Here in BC, we have a very low exposure limit for silica, 0.025 milligrams per cubic meter, which is the ACGIH-TLD. And one of the things in the regulation, and I believe this is in many other jurisdictions have this as well, is that if you're going to be, you need to use monitoring data for decision making, but you don't necessarily need to do your own monitoring. It can be objective monitoring data that was collected through equivalent work operations, through industry surveys, or peer-reviewed or scientific studies. So the aim of our project was really to get a lot of information together in one place where employers could actually use it. So in the construction industry, there are many challenges to exposure assessment. The sites are rapidly changing all the time just by the nature of the work. Workers are moving between sites. There's contractors coming and going. People do different tasks within one shift, or from shift to shift, they do different things. The exposures vary. And most construction companies don't have a hygienist. They don't have any expertise. They don't have the in-house capacity to develop an exposure control plan. Most are small employers. 95% have less than 10 employees, and most of those in BC have less than 5. And I think it's similar in many other jurisdictions where construction is just made up of small businesses. So with that in mind, for this particular industry, it was going to be very difficult to come up to do a lot of measurements, to access scientific data, to even to hire consultants, because there aren't always consultants available, and they're very expensive. So we developed this thing called the Silica Control Tool to help employers use existing data. We also, it's an online platform where we have a model that estimates silica exposure based on our database that we put together. And also we have a lot of educational information in there about silica, about hygiene best practices, about how to use controls, about the hierarchy of controls. And the aim is really to help people to develop effective exposure control plans, to reduce the effort and the cost associated with doing that, which is very important, because the easier it is, the more likely it is people are to do it, and to improve the quality of exposure data used in risk assessment. So because we put together this database, we were able to kind of do some quality control on what data actually went into our database. So we have this database of over 5,000 personal exposure measurements that a lot of them come from the scientific literature, from government databases. We abstracted them all into a database. We piggybacked on some previous work that did a lot of this. We've done some of our own monitoring to fill in some of the gaps in the database. And basically then we built a linear regression model using this database to predict the exposure level of common construction tasks and scenarios, both with and without engineering controls. And then we compare them to the exposure limit and create an electronic and paper exposure control plan that employers can use. They can share with workers, they can share with enforcement officers, or anybody, or with contractors, anybody who they need to share information with. So just in conclusion, my final thoughts are, so the data that we have, we are a British Columbia based organization, and the tool was built for British Columbia. It's available to all employers in British Columbia, but it's not, the most of the data in it is not from British Columbia. Some of it is, but not all. So it could be calibrated for use in other jurisdictions. And one of the real strengths of this approach is measurements can now be pooled and used more than once. So what we find now is employers, they'll get in touch with us and tell us, you know, the activity that we want to do is not in the tool. So then we say, oh, great. And we go out and sample, and then we put it in our database. And then that measurement can now be used by everybody in their risk assessment. Also, the people who use it, they can compare the control effectiveness. So if they look and they see, oh, with wetting, I'm probably going to get this effect. With exhaust ventilation, I'll probably get this effect, and they can see what's going to be more effective. We can be adaptive to new technologies. We're adding new controls, new processes to it all the time. And we found that it has encouraged industry engagement. Like, people like using it. They like to contribute to it. They like to. It's enabled in British Columbia. We found it's able to it's enabled a lot of collaboration and data sharing. That's all I have to say about that for now, because I know we don't have much time. So thank you very much. And I have no idea if there's time for questions, but if not, I'll just pass it over to Dion.
Yeah, for everybody that just do two things. Send a note to Dr. Eng in the chat box and hold on to them, because on the roundtable we'll have another opportunity for Q&A. Okay. So Dr. Williams from OSHA.
Great, perfect. So this is a brief overview of OSHA's enforcement since publication of our silica rule in 2016. This rule reduced our permissible exposure limit from 100 micrograms per meters cubed down to 50 micrograms per meters cubed. And it includes a number of control measures that employers must implement, and that must be outlined in a written exposure control plan for all employers who are covered by the rule. It also includes exposure assessment, and as Melanie mentioned, one option that employers have is the performance option, which may rely on objective data to characterize exposures. Employers also may do their own monitoring under the scheduled monitoring, which is the traditional sampling approach. If they're doing the scheduled monitoring, the standard lets them know when and how often they must do air monitoring based on prior results. For the construction industry, there's a unique provision that allows employers to use Table 1, and Table 1 specifies certain exposure control methods that are outlined for 18 common construction tasks. So if an employer is following Table 1 accurately, they do not have to assess worker exposures. It's assumed that the exposures have been assessed based on the specified controls in that table. Where employers are not following Table 1, or if they are doing tasks that are not included in Table 1, then they must follow the alternative exposure control methods. And under that plan, they would have to do exposure assessment and comply with the Pell. So this just shows an overview of OSHA's own sampling for the 10-year period from 2008 through 2017, when OSHA was implementing a national emphasis program. The national emphasis program is a program where we targeted specific industries known to have high levels of exposures to silica. So this just shows the sampling done in that period, and about 14% of the personal air samples resulted in exposures greater than the Pell. The Pell at this point was the 100 micrograms per meters cubed. In 2017, at the end of fiscal year 2017, we temporarily suspended our national emphasis program so that we could revise the program to align with the new requirements under the silica standard. So this slide just shows inspections and sampling that was done in fiscal year 2018, the year following that suspension of the NEP. Our number of inspections, we saw a reduction, and we expected that to happen. On average, under the National Emphasis Program, OSHA was doing about 650 inspections each year, and in 2018, we saw 300. And then the personal air samples, about 18% of those we saw exceeded the new Pell. This just shows specific inspection data for the cut stone and stone product manufacturing, and it compares fiscal year 2017, which is the last year of our national emphasis program, with the subsequent years up to 2021. This is my last slide. We have revised the National Emphasis Program. We published it in February of 2020, but that was right around the time that COVID-19 became a significant concern. And so our enforcement efforts have been diverted somewhat from some of our other health hazards, including silica. So we haven't yet seen the number of inspections rise to the levels they were under the old National Emphasis Program, but we do anticipate that within the next year or two, once COVID-19 emphasis is reduced, we will see those numbers rise again. We do have a regional emphasis program in our Denver region that is specifically addressing the cut stone and slab handling industry. It was issued in February of this year, and it is effective as of May 17th, and it will run up to February 2027. Lastly, I just want to mention some rulemaking efforts underway. In 2019, OSHA issued a request for information for additional information and exposure data for tasks that are not included in Table 1 in the construction industry. We have since gotten about 100 comments, but very limited exposure data. So we would have appreciated getting more exposure data to help us to really augment this table. We do anticipate publishing a notice of proposed revisions to the table later this year based on the feedback that we've received. And there's also some rulemaking efforts underway to address the deficiency in medical removal. This standard does not have a medical removal provision, and so OSHA is undertaking some rulemaking efforts in that front. With that, there are a number of compliance assistance tools that are available on OSHA's website. I know we're limited with time, but to the extent that we have you have questions that I may be able to answer, we can do that. And the slides, I can make these slides available for those who are interested. And thank you.
Thank you very much. So our next pair of presenters include Doctors Ryan Hoy and Bob Harrison. And I don't know if Dr. Harrison is on, but Dr. Hoy, it's your turn.
Great, thanks very much. Yeah, I think Bob is on. I've seen Bob down the bottom there. I'll try to not eat into his time as well. But thanks for the opportunity to talk this morning. I'm going to give you a really quick snapshot of what the problems we've been facing in terms of artificial stone and silicosis and our experience here from Victoria over the last few years. I thought I'd give you a little bit of background leading into Bob's talk as well. Here in the Southern Hemisphere, we tend to talk about bench tops. I think in the Northern Hemisphere, we tend to talk about countertops. But this material is referred to by various names. We talk about artificial stone, engineered stone, reconstituted stone, quartz conglomerate. So it just goes on and on, the different names, which makes it very difficult to actually identify this material sometimes. But there's a material that developed in Europe in the 80s. We've started to import into Australia in the early 2000s. So it hasn't really been with us for a huge length of time. Lots of different manufacturers of this material. Caesar Stone, certainly here in Australia, has got the largest proportion of the market, but there's lots of other companies that do produce it. Really, really attractive for a domestic market for kitchens. Much cheaper than a lot of natural stones. You get any color that you want. So it's really become extremely popular, and it's a huge business. So this industry now is worth $15 billion per year. And this one company has had a greater than 6-fold increase in revenue over the last 7 years or so. So it's really exploded in popularity over that period of time. Essentially, the material is an artificial material. So there's a quartz containing rock, which is crushed into it's almost a sand-like consistency, mixed with resins and pigments and other factors. and then it goes through this vibrocompaction process and it's heat cured. And then at the end of that, you get this slab. And so obviously this slab's not what you put into your kitchen or your bathroom. It needs to be modified to go into that based on what your design is for your kitchen. And so this is work that's done by benchtop fabricators. So they typically use hand tools. Some more sophisticated companies may use computer operated equipment to do this, but the vast majority use pretty basic tools like a handheld grinder to do this work. So cutting out the inserts for the sink and the cooktop, for example, and then the installer will then make some other modifications when they put it into your house. And then this is the final product. So you get a flash new kitchen, which, with the envy of your friends. So what's the problem? Essentially, it's the silica content. This is a really, really hazardous material. So greater than 85% crystalline silica. This was pretty shocking when we first saw the silica content of this material, really equivalent to the amount of silica that's in sandstone. But workers had been using marble and granite, which has far, far less silica than this material. Then it was suddenly introduced in the early 2000s and had very little education about the risk related to it. So really, it's an absolutely perfect condition with its own benchtop fabrication business to actually cause silicosis. So you've got workers that are using these really high intensity power tools. They're cutting and grinding and polishing this very high silica containing material. Little dust control measures have been really common. So a lot of people are doing this work with no water dust suppression at all. They're producing really very fine respirable particles, really high peaks of intensity of silica exposure, and these freshly fractured particles as well. And there's other components of the dust too. So resins, metals, and other factors which are going to be contributing towards the toxicity of that dust. And really it was with increased awareness in the media, a lot of workers speaking out about how terrible these conditions were at these workplaces and their struggles with silicosis. There's been more government response to this problem. And this has been through initially health assessment programs, and we've been involved in one here in Melbourne, or certainly here in Victoria, which has provided a bit of insight into how significant and how major the problems are in this industry. So we've been involved in this program that's been run since mid-2019. And this is a free health assessment program. It's a program that's been really focused on the stone benchtop industry. I can share the protocol with anybody who wishes, and we've published this online, but it's a very detailed health assessment. And essentially over the first 2 years of the program, obviously interrupted by COVID, but through that time we had 402 workers that had finished the program, and we had a final diagnosis for them. And really shockingly, we had 26% of that group that had a diagnosis of silicosis. 89 with simple silicosis and 18 with complicated silicosis. And you can see here, just based on the CT imaging, the range of severity of disease that we've been seeing. And I think what's important to note here is that this is essentially a workforce of men. So 93% of the screened workers were male, 100% with a diagnosis were male, and relatively young men, so in their 40s. And this is a very physical job, so they're quite fit young men. And so they have significant respiratory reserve. So it's only with screening that you're actually going to identify these people with disease, unless you wait until they develop very severe end-stage disease and they're very symptomatic. So, and I'll just, in my last moment, before handing over to Bob, just to note also that we capture also cases of silicosis beyond the stone benchtop screening program. And we had close to 200 cases over that 2-year period. Normally here in Victoria, we would see about 8 cases per year. So this is a really huge increase in terms of the cases. And listen, there's nothing special about the industry here in Victoria. This will be the same in any country around the world that uses this material. We've certainly seen similar results coming from Spain, where they have been much more proactive in terms of screening. We're seeing a lot of results coming out of China of major problems there as well. but only with screening are you going to identify, the workers that are affected by this condition and how bad the problem is in this industry. So thanks very much. So Bob, I'll hand over to you now. I'll just stop my screen sharing, and I think we'll have time a little bit later on for a bit more discussion.
Thank you, Ryan. Bob, can you jump
There you
in?
go. Thank you, David. Thanks for unmuting me. I thought you had me muzzled there, David, but thank you. So thanks so much for joining you from California. And thanks so much, Ryan, for publishing such fantastic work from Australia. We've been adopting and promoting your protocol in Australia, and I saw there was a chat. And Ryan, maybe you could put the link for the participants about where to get that. It's incredibly useful and thoughtful. Just prior to COVID in September of 2019, we published really just a case series of 18 workers with severe silicosis. We call it engineered stone here in the US, but it's the same exact process that Ryan is describing from Australia and that's done throughout the world. This was keeping me up at night before the COVID pandemic hit in January of 2020. And then the COVID pandemic kept me up at night for the last 2 years. And I'm really welcoming returning to this focus on silicosis. During the pandemic, I've been told by the industry and workers that business is never better than it was before, that this continues to increase in sales. Like Australia, artificial engineered stone is about 90% of the market in residential and commercial installations. And I really call it silicosis in a box, because if you ever had to make a product, and this is a long, quite interesting history that dates from a patent in Italy in 1985 by Marcello Tonselli, who started a company called Breton, who licensed this to about 100 companies globally. This was back engineered and manufactured off patent by about 100 Chinese manufacturers who captured about 50% of the global market. We had a patent war in the United States about 3 years ago, and we're seeing much less Chinese product come into the US. But that hasn't stopped the rising sales opportunities. And I was watching this in 2012 when the first paper was reported in a case series from Israel. I think it was 25 severe silicosis cases, half of whom needed lung transplants, and waiting for the shoe to drop in the United States. And sure enough, we published the first case report simply as a consequence of this blog, this basically posting that said, if you know anybody, if you've seen any patients, let us know. And this was posted on the Public Health, our National Centers for Disease Control website. Gary Friedman, a Texas pulmonary doctor, read that blog and reported the first case here we published in 2015. Again, this is a real challenge in public health reporting and disease reporting in the United States and probably globally, is how do we find these early cases? We found our cases in California because one of my epidemiologists walked into my office in January of 2019, and she was checking our hospital discharge data from 2017. And she found a case in a young guy who was hospitalized with silicosis. And when I got his medical records and I interviewed him, turned out he had worked in a stone countertop since 2004. And he was diagnosed with silicosis in 2013. So Ryan, it fits the period. I think you had an average of about 7 to 10 years in Australia. He gradually got worse. By 2017, 2018, his lung disease has progressed so substantially that he was referred for evaluation of a lung transplantation. But by that time, he was not eligible, and he died of accelerated silicosis in 2018. And I didn't find out about him until 2019, right? So you'd wonder, why between 2013 and 2019 was his case not reported? Or did the public health authorities not find out about it? And I am the public health authority in California, by the way, not the only one, but I'm the guy that's watching over this system. And when I interviewed his brother, who was still alive, to find out about what happened to this guy, he said, well, my other brother worked for the same shop and he died of stone in his lungs. And that was the literal translation in Spanish. I don't know Spanish. I wish I did, but I said, what is stone in the lungs? And it turned out his brother had worked in the same place, had died about a year before, had had an autopsy done at a local coroner's office. He had an enlarged heart and very firm lungs when the coroner palpated the lungs. And I looked for the microscopic. Where was the histology? Where was the slide cuts? None were done. So I got the permission from the father and I retrieved a bottle, literally a bottle of formalin tissue, not knowing if there was lung in there. And sure enough, there was lung tissue in there. And I sent it over to Kirk Jones, a nationally well-respected expert in occupational lung disease pathology. And sure enough, Kirk found the classic findings of alveolar proteinosis, very, very extensive lung disease. By the way, I tried to then get the coroner to revise the cause of death with total refusal, not incommunicado, never got the cause of death. So now there is two brothers buried side by side in a rural cemetery in Guatemala, neither of whom ever got compensated, neither of whom really got eligible for a lung transplant or got the necessary care. And so this story is, I could tell you time and again what this has happened in the same way. We now have about 20 cases, really all through detective work. And so let me tell you just about a couple of things that I'm trying to do with my team in California that I've thought about lately, and I'd love others around the world or participants in this discussion to give me your thoughts. First is we have an electronic health record system. It's actually in the United States as a whole, and I don't know whether it's throughout other parts of the world, but we now have the ability to push silicosis diagnoses from the electronic health records directly to the public health system. We're using a software platform that's supported by the Centers for Disease Control. And we're going to initiate that in California and have about 25 major health systems push the ICD code for silicosis in the hopes of getting this diagnosis, which was delayed 6 years to my attention, to be pushed earlier so we can identify cases. The second is the notion that establishments that are running businesses in our state of California, really anybody could open up a stone fabrication shop. There's no special license or expertise required. They must comply with our OSHA silica standard. But when we have between 500 and 750 shops, most of them are very small. Our OSHA program will never be able to get to inspect these shops. And I'm not sure that even after these shops are inspected, silica dust levels drop, quite honestly. And we've just analyzed some data at about half of our OSHA inspections found silica well over the PEL. And we simply don't have the resources to go back to these shops. I would like to regulate silica like we regulate asbestos, which is that you must be a licensed stone fabricator and pass a minimum set of requirements and proficiency, including showing how you are going to comply with the OSHA standard. So I want to make this a separate registry, and I wondered whether other countries or areas around the globe have thought about this or tried this. So with that, I'll end and pass it back on to you, David.
Thank you very much, Bob. Just a really brief question. You mentioned 20 cases. Is that 20 cases in California, or is that 20 cases above and beyond those that you put in that MMWR report from 2018?
Well, we had 6 in 2018, David, and we now have close to 20 in California.
Okay.
Yeah, and we're updating publication and publishing those cases. But they're honestly more of the same, David. I have to say that there isn't anything terribly new or surprising in the clinical presentation. I think the challenge is now, what kind of policies can we put in place globally? Because this is duplicated throughout the world. And of course, we've known about silica dust for 2,000 years. And we know that these shops, particularly small ones, are extremely dusty. How to get these under control?
Okay. Well, again, we're going to have an opportunity on the roundtable to talk about this a little bit more. I now want to ask my colleague, Rodney Ehrlich from the University of Cape Town in South Africa to make his presentation.
Thanks very much. Good evening from Cape Town. I've been asked to talk about another complication of silicosis, tuberculosis, which is well known to us in South Africa. So I'm going to say a few things about estimation of risk and implications with regard to tuberculosis for the follow-up of silicosis. And I acknowledge my colleagues Zodwa Ndlovu and Jill Murray, who provided information about the South African autopsy service. So I just really want to touch on three themes. One is a recent systematic review, which we published last year on risk, relative risk. The second is the South African miner's lung autopsy system, which may not be known to many people who don't follow pathology literature. And thirdly, some observations on what do we do to follow up silicosis in silica-exposed populations, particularly in low resource settings. The systematic review, by the 1950s, really interest in silico-tuberculosis had faded in developing countries. If you look at the literature, silicosis had declined in severity to what was now been called simple silicosis, unfortunately. TB became treatable and waned as a social threat. However, it was clear to us by the 1990s that there was a severe triple epidemic of silicosis tuberculosis, such as had not been seen for 100 years in South Africa, aggravated by HIV. And as we've heard this evening, the 21st century renewed interest in silicosis in developing countries, in particular outbreaks of accelerated silicosis in developed countries. However, our view is this has not been matched by critical research into silico-tuberculosis. In fact, as recently as a few years ago at the Dublin conference, the association between silicosis and TB was questioned, not necessarily critically, but just for the lack of up-to-date analysis of the association. So we undertook a systematic review, and I'm going to present two of the forest plots. This is the relationship between silicosis, the disease, and incident tuberculosis. So we included only cohort studies and case control studies in which the tuberculosis was validated either bacteriologically or through some national registry system. And we found only 9 studies. The last one was done in 2013. 5 came from low or intermediate burden TB countries. 4 came from 1 high TB burden country, which is South Africa. We found a pooled relative risk of 4, a very strong association. And using the criteria of for systematic reviews, we concluded a high confidence in the strong association between silicosis and TB. And for us, that puts us in the modern sense beyond any doubt. When it came to the relationship between silica exposure after excluding silicosis, so the studies had to have some means of controlling for silicosis. And really, epidemiologically, you can only control for radiological silicosis. I'll come back to that. We found a pooled relative risk. We had 5 studies. We found a pooled relative risk of 1.92, somewhat less, but still in the good moderate range. However, again, using the Gray criteria for systematic reviews, we concluded this with low confidence. And the main reason for the low confidence was the absence of reliable and precise cumulative measures of respirable silica exposure in these studies. Proxies for exposure were used, and no doubt this would have resulted in a lot of misclassification. So really do need to accumulate high quality data over a long time to answer this sort of question. Moving on to the pathology automation system, or PathOut as it's known, South Africa. So this is really peculiar to South Africa's 100-year history of mining and contestation between unions, white miners' unions in the colonial and apartheid days mainly, the government and the industry. So South Africa has requirement, a legal requirements for a heart and lung autopsy in all miners who come to the attention of doctors, whose death comes to the attention of doctors, with the consent of next of kin and irrespective of the cause of death. The purpose is to ensure that people who do die with silicosis, their family has an opportunity to benefit from the compensation. The PathOut system has accumulated 110,000 autopsies in its archives since 1975, the majority being gold miners. However, the one bias of the system is that migrant ex-miners from South African rural areas and from neighboring countries certainly are severely underrepresented because of the scarcity of pathology services in home areas. The heart and lungs actually have to be sent to Johannesburg to a central laboratory. You can read about that in the references given. So I just want to present two sets of results from the PathOut system analysis, which gives us some idea of the value that one can gain. So the first one is surveillance. So autopsy is, of course, not an accurate representation of the population. It still gives us very important information. So this slide, or the analysis here, is divided to black miners who make up mammoth production workers and heavily exposed, dust exposed part of the workforce, and most of them are migrant, revolving contracts which may last from 1 year to 30 years. White miners are at the supervisory level, usually blasters and mine supervisors, and they tend to be lifelong miners spending their whole career up to until recently in the mining sector. And they have very different epidemiologies, also come from different social strata within South Africa. So the first two panels, the top panel, that's A and C, what we see here is between up till about 1990, elevated levels of silicosis TB, but in 1990s, this dramatic increase in tuberculosis and in silicosis. In the case of silicosis, proportion of autopsies showing silicosis from 3% in 1975 to 33% by 2014. Pulmonary tuberculosis also in the sky. So what are the factors underlying that? Well, HIV was really the calamity of the 1990s and its close relation to TB. But silicosis itself, as we've shown, has a strong association with TB. And if you go to the lower panel, you would see that the average duration that's spent by black miners in the mine increased from about the average from about 5 years in 1975 to 18 years of autopsy, without necessarily any increase in dust level. The mere accumulation of year after year of silica exposure is sufficient, we believe, to drive a significant epidemic of silicosis. White miners, as I say, have a different epidemiology. They've always had historically very high rates of silicosis. That was falling until the 1990s, also has increased, but their duration of exposure, you can see from the last panel, has not increased. And that, at the moment, defies easy explanation, but certainly they suffer from the increase in silicosis and TB as well. The second result, or the second set of information that's useful to us, is the traditional function of autopsies. How well is disease detected in life? Two critical studies. One is comparing the proportion of silicosis found at autopsy to chest X-ray reading in life. These people all had chest X-rays using the ILO threshold of greater than 1.0. For any silicosis detected at autopsy, 57% was not detected on a chest X-ray. Or you can say much of it with mild pathological silicosis. However, even for moderate and marked silicosis found at autopsy, 38% was not detected on a chest X-ray. I think this is an issue which is greatly underestimated or perhaps not even known, that a large proportion of silicosis is subradiological. And so we need, when we talk about early detection, we need to rethink how that's going to be. For tuberculosis, between 1996 and 2000, of 1,500 active pulmonary tuberculosis cases at autopsy, 64% was not diagnosed in life. So we're certainly missing plenty of tuberculosis. Again, important implications for surveillance. So just to end off, if we're going to follow up silicosis and silica-exposed populations, we need a few things. So if there's no TB, it's not going to be a problem. However, one does need an understanding of the relevant background TB epidemiology, which varies. Many of the mining countries, South Africa, China, India, etc., also high TB burden countries. the migrant population might not even be local. And so one needs to understand really the epidemiology of the population of the area or the region or the country from which the workers come. Secondly, one needs chest x-rays experienced in distinguishing active tuberculosis, prior tuberculosis, silicosis, and a combination of disease without CT scan available at hospitals, because in fact, a lot of the surveillance takes place in areas where access to CT is simply not available or only on referral to a hospital center. However, there are recent developments in computer-aided detection now well established for tuberculosis and more recently for silicosis, which if used creatively could come and bridge this gap. In recent TB prevalence studies in South Africa, 50% of cases were asymptomatic. So symptoms, in fact, for mass screening of this nature are not sufficient. So what is required for where there is a risk as for silicosis and silica exposed workers, a very low threshold for using laboratory investigations, such as gene X, traditional smear or culture. And finally, consideration of the viability of a program for treatment of latent TB infection. Now, the WHO does not recommend such programs at this stage for low-income countries. However, given the nature of the problem, but also the difficulties of managing such a program that needs to be considered, particularly in the light of recent novel short course regimens for treatment of latent TB. I think it'll leave you some homework, some research questions, which I don't have time to cover. This will be up on the web and references if you're interested. Thanks very much, David.
Thank you, Rodney, very much. I'm going to talk a little bit about silicosis, and I think I've got the right thing here. Let's see. Can everybody see this?
Yes, we can see it.
Thank you. So here's my information, and I'm very pleased to have Dr. Ehrlich's presentation. Here's my conflict of interest. I do want you to know I've consulted with these agencies, but the views expressed are in this talk are my own. So very briefly, we know that respirable silica causes silicosis, silicotuberculosis, autoimmune diseases, lung and other cancers, and kidney disease. But we know that the data in the US is vastly underestimated. In the world, if you look at this on a worldwide basis, there may be between 2 and 4 million US workers and some 100 million workers worldwide exposed to silica in mining, coal mining, construction and demolition, metallurgy, ceramics, agriculture, sandblasting, and especially we've just had some concern about tabletop manufacturing. We're unsure of the global estimate of the number of workers with silicosis, though I do think it's very important to recognize the work in South Africa for Pathot has given us something that is quite valuable scientifically. We do need to recognize that since the mid-1980s, that we need to think about silica in the same way that we think about smoking and asbestos. In other words, that it's a multi-potential hazard, and we need to look at this in terms of very strongly focused prevention activities. So here is a standard chest x-ray that Rodney was just talking about. This is a very poor way, by comparison with autopsy, to be able to determine if someone is sick or not. Nevertheless, we have a great deal of reliance on these standard chest x-rays, and the CT scan offers an improvement, but it's still apparently not as good as an autopsy. So what is necessary for the diagnosis of a chronic lung disease like silicosis? Have to have a sufficient workplace exposure to silica or coal, and we certainly would be better served if we had industrial hygiene data to back that up. We need X-ray evidence of biopsy or autopsy or other clinical evidence of silicosis, non-malignant respiratory disease. We need to look at the cancers. We need to make it clear whether or not the patient has silicotuberculosis, whether they have kidney disease or autoimmune disease. We also need to focus on the disease symptoms and rule out other possibilities, keeping in mind, at least in the United States, that when we talk about severe silicosis or co-workers pneumoconiosis, a lung transplant is very expensive, and it usually falls on the patient's shoulders to the tune of some $20,000 to $50,000. So I very briefly want to share with you some work that we did in the 1990s for claimants with silicosis in California. And this is a group that I've divided this up into non-cancer. The next slide, we'll talk about cancer. One of the things that is worth noting is that the risk of death for tuberculosis after a claim for silicosis was 56.4. That's extraordinarily high. There's also elevated risks for non-malignant respiratory disease, for emphysema and silicosis and other pneumoconioses, and these are all statistically significant. It is also true that all causes of death is elevated for about 30% higher than expected. And I also then just want to show you a little bit about the cancers. There is some very interesting findings for malignant neoplasms of the digestive organ, a slight elevated risk of about 25% in SMR of 1.24. We also found a malignant neoplasms of the large intestine had a doubling of risk, and we found also a doubling of risk for lung and respiratory cancer. Keeping things in perspective, it's also worth noting that the risk for prostate is only 0.3. So we did not see cancers all across the board. So I also now want to share with you some data from the Michigan Silicosis Registry. McColl et al. From 2010 looked at autoimmune diseases. They found 33 cases of rheumatoid arthritis producing a relative risk of nearly 7, 1 case of lupus, which really doesn't really say very much because the confidence intervals are so wide, 2 cases of scleroderma, the same thing, 2 cases of Sjogren's syndrome, and 6 cases of ANCA-associated vasculitis, producing an elevated risk of 25 with a 95% confidence of 6.3 to 101. So autoimmune diseases have tended not to be focused on so much, but they should be part of our sphere of concern here. And we should undertake studies that look after the silicosis is diagnosed to see if they have higher risk for autoimmune diseases as well as cancer. I want to share with you something that has just came to my attention, a brand new study, which I believe is still in press. The author is by Cohen and colleague. The study is a pathology and mineralogy assessment of a group of US coal miners, and they compared the pathology and mineralogical features of 23 contemporary coal miners compared to 62 historical coal miners. And what they found, I found to be extremely interesting. There was a significantly higher proportion of silica type pulmonary massive fibrosis, 57% compared to 18% among current miners. The authors found exposure to respirable crystalline silica to be the cause of the severe lung disease that has been shown in contemporary miners. And this is going to be talked about very soon after the break by Dr. Hall. But I wanted to share this brand new study, pathology study with you all. So what do we need to do now? We need to increase educational focus on effects of smoking and other hazards. We need to include radon and diesel emissions in mines, polycyclic aromatic hydrocarbons in foundries, asbestos and arsenic in combination with silica. We need to really get involved in silica prevention efforts and make dust control and wet methods the highest corporate and medical investment, as we know that this is a clear-cut way to lower the severity of the problems that we're dealing with here. We need to add that we should include TB and autoimmune surveillance, and we have to expand surveillance to minority and Spanish-speaking workers in the US. And as I have been able to make sense of what you're talking about, for example, in Australia and in South Africa, we really need to understand that this silica issue is strongly linked with concerns about migrant workers, and they need extra effort for outreach purposes. So thank you very much. We need to include students and young investigators. We must have greater funding and corporate investment in prevention. And I would just like to put in a plug one more time to join your occupational and public health professional societies, including Workplace Health Without Borders in the UK, Australia, US, and on the international scene as well. So thank you very much. And my understanding is that we're going to take a little bit of a break, and we're going to reconvene at 6:05, unless it is already 6:05, which it is 1 minute away. So everyone take a 5-minute break. Let's reconvene at 6:10, if that's all right with everyone. Thank you all. See you in 5 minutes. We're going to have our presentation from follow-up of co-workers pneumoconiosis. That's what CWP stands for, patients. And our speakers are Dr. Sheikh Alif and Noemi Hall.
This is my disclosure. So this presentation is not related to any commercial supporter, and I do not have any conflict of interest. So first, I acknowledge the country, the traditional owner of the land where we work, and pay my respect to the past, present, and elders. So good morning to those are in Australia, and good evening to our US colleagues, and welcome to everyone. And thanks to Dr. David for giving the opportunity to present in this session. My name is Sheikh Alif. I'm working as a research fellow at Monash University. So this talk is not basically on the CWP patient, but we did a review on cancer and mortality among coal mine workers. So I'll present about that and a little bit information about CWP cases in Australia. So we know that the coal mining, the coal is Australia's largest energy resource, and around 60% of the nation's electricity and power supply is currently produced by the coal-fired power stations. Black coal is used to produce coke, which is mainly used in the blast furnace that produce the iron and steel. Black coal is also used in other applications like cement manufacturing, aluminum refineries, and paper manufacturers. In Australia, the black coal resource occurs in New South Wales, Queensland, South Australia, Tasmania, and Western Australia. And also the brown coal occurs in other parts like South Australia, Western Australia, Tasmania, Queensland, and in Victoria. Nearly 80% coal produced in Australia is from open-cut mines, in contrast with the rest of the world where the open-cut mining accounts 40% of coal production. The open-cut mining is cheaper than underground mining, and Australia is world's 4th coal producer country behind China, US, and India. So there is some recent data from Resource Safety and Health Queensland, RSHQ, which receives the reports from disease from a variety of sources, including medical advisors and site engineers, and through the Workers' Compensation Scheme. So this is the figure that displays that reported cases since 1984, and figures are updated and published on every month in the RSHQ website. So that multiple mine dust lung disease, MDLT, which includes that CWP, silicosis, mixed dust pneumoconiosis, COPD, asbestosis, and cancer. And the reported case of CWP have decreased in recent years, as we can see in the figure 2, while the reports of silicosis and COPD cases have increased. This may be attributed due to increasing awareness of occupational lung disease in the open cut coal mining and mineral mine and quarry sectors. As of 31st of March 2020, RSHQ has identified 147 pneumoconiosis cases, including 56 CWP cases and 262 mine dust lung disease cases, of which 147 were pneumoconiosis cases. And the prevalence rate estimated have increased over time, that primarily due to increased number of diagnoses, particularly since the later early 2000, and the inclusion of both newly diagnosed and pre-existing cases in this population. It should be noted that the prevalence also differs from the incidence in this table. And the recent data also suggests that chest X-ray screening of these coal mine workers in Queensland have identified around 120,000 cases without any disease, and 46 confirmed cases. So the coal mining is an occupation with different sort of exposure, including coal and silica dust. And IARC, the International Agency for Research on Cancer, have identified that coal dust as a group 3 carcinogen, which is not classified as a human carcinogen. However, the crystalline silica is classified as a group 1 carcinogen. And exposure to coal dust and silica dust can result in various diseases, including different type of cancer, non-malignant respiratory disease, including COPD, and may increase the risk of other type of cancer, including stomach cancer or prostate cancer. And exposure to coal mine dust and crystalline silica may result in other disease, lung disease, interstitial lung disease, including coal workers silicosis, pneumoconiosis, silicosis, and mixed dust pneumoconiosis. However, there is very limited epidemiological evidence that suggests that this association does exist and what type of exact type of cancer and mortality. So before this study, there was no systematic review, and that particularly conducted on the coal mine workers to analyze these findings. So we systematically analyzed and meta-analyzed the evidence of cancer and mortality among coal mine workers. This paper was published last year in Occupational and Environmental Medicine Journal. So we search in different databases, including the Ovid Medline, PubMed, and Embase by Ovid, including the 2 sets of keywords, and combined with medical subject heading measurings. So we used coal dust related, exposure related keywords, as well as outcome, cancer, mortality, and combined with causes of death and hospital mortality. We also searched the list of references in WHO documents, SAC documents, and all the retrieved reference list. But we didn't include any grey literature for this work. So we had particular some inclusion and exclusion criteria. So we included published peer-reviewed studies that investigated mortality and cancer in coal miners. We included studies that conducted on human adults, and only the English language literature was included. We excluded those studies have not reported any coal dust related exposure or no outcomes. And we didn't include any case series, case report, reviews, and editorials. And we also excluded that repeated publication from the same cohort in the same year. So we extracted the data from all the studies that we included, and bias were assessed using the STROP guidelines. Methodological quality of the included studies were assessed using Newcastle Ottawa Quality Assessment Scale. We used random effect modeling, and forest plot were generated to estimate the pool analysis. We used a funnel plot, Beck's funnel plot, and Egas test to assess the publication bias. The outcome was stratified by population type, which is coal miners with CWP and unknown CWP status, and a forest plot, and calculated for all the outcomes, including all-cause mortality and cause-specific mortality, including lung cancer, deaths from non-malignant respiratory disease, COPD, cardiovascular and cerebrovascular disease. And there was quite a bit of variability in the included studies. So the cohort studies reported SMR and SIR, and most of the case control studies, they reported odds ratio. So that's we combined some of these estimates to report. And the risk of, we use this data to analyze our data. So this is the Prisma flowchart that that the study we conducted. So initially, we started with 446 records through the electronic database, and 406 full text were screened, and 174 were assessed for eligibility, 138 were excluded for different reasons, and finally 36 peer review articles were included in the systematic review and 21 in the meta-analysis. So this is one of the forest plot for our analysis, that risk of all-cause mortality. As we can see that all-cause mortality SMRs were drawn from 6 studies in this first forest plot and did not show a significant association with coal mine workers. And as you can see, that's pooled estimates here. And the heterogeneity between the studies were quite high, 94 to 95%. And there was a significant increased risk of all-cause mortality in for the 3 studies on cohorts of coal mine workers with CWP. So that's the pooled estimate were near to significant. And the pooled results of 8 studies on coal mine workers without CWP did not show any significant association between coal mine workers and lung cancer as well. So no association was observed in as well as the coal miners with CWP from 2 studies. The 3 studies reported also the other type of cancer, other type of lung cancer, including lung, trachea, and bronchus, which also did not find significant association. So this is the forest plot for stomach cancer and the risk for mortality on cardiovascular and cerebrovascular disease. So the meta-analysis of 9 studies of stomach cancer had an effect estimates of 1.11, which is near to significant but not significant. The risk for the cohort with minus with CWP is also not significant. And we did not find any association with coal miners with unknown CWP cases with cardiovascular disease, as well as coal miners with CWP. Sensitivity analysis, we also conducted several sensitivity analyses that also showed that their results were not affected by any individual studies. The meta-analysis for the risk of deaths of cardiovascular disease also not significant. The meta-analysis that investigated the risk of non-malignant respiratory disease in coal miner with unknown CWP status from 5 studies that showed that SMR were 1.26 with 95% confidence interval is near to significant. As expected, there was a significant increased risk of death from non-malignant respiratory disease observed for the cohorts of coal miners with CWP, which is 3.59. The risk of mortality from COPD was also increased in coal miners, which is 1.13 SMR with the 1.05 to 1.122. And the sensitivity analysis showed that the results were not affected by any individual study. So to summarize, that we found that increased risk of all-cause mortality and mortality from non-malignant respiratory disease in cohort with coal worker pneumoconiosis. We found somewhat increased risk of stomach cancer and of the mortality of non-malignant respiratory disease in coal miners with unknown CWP status, but there is no evidence of an increased risk of lung and prostate cancer. cardiovascular and cerebrovascular mortality were also lower than expected. So most of the studies included in this review didn't include exposure assessment, and the cohorts lacked smoking data, so that might influence the result. And the coal mine workers are at increased risk of non-malignant respiratory disease mortality, but there was no clearly increased risk of lung cancer, so that the non-malignant respiratory disease mortality most likely due to the coal mine dust other than smoking. This suggests that workplace dust exposure has not been adequately controlled in this industry. Thank you very much.
Thank you very much. Like to have Noemi Hall, Dr. Hall from NIOSH, please.
Okay, there we go. So thank you. My name is Noemi Hall, and I'm an epidemiologist within the surveillance branch of the Respiratory Health Division at the National Institute for Occupational Safety and Health in Morgantown, West Virginia. I will do my best to be brief today, describing the data that we collect here and recent findings regarding silicosis and pneumoconiosis among working coal miners in the United States. So as a result of the Coal Mine Health and Safety Act of 1969, NIOSH has administered the Coal Workers Health Surveillance Program, or CWHSP, since 1970, which offers chest radiographs at no cost to coal miners at regular intervals during their career. Participation in this program is voluntary. And this program is unique to occupational health. Coal miners are the only US workforce for which industry-wide occupational respiratory disease data are systematically collected. And this data is used to monitor trends in pneumoconiosis, black lung, across the United States. The radiographic data from the CWHSP has allowed NIOSH to study risk factors for pneumoconiosis and monitor national pneumoconiosis trends for nearly 50 years. An important purpose of our radiographic surveillance is early detection of dust-induced interstitial lung disease in working coal miners and preventing progression to more severe forms of pneumoconiosis, such as progressive massive fibrosis, or PMF, through reduction or elimination of future exposure to coal mine dust. Using data from the CWHSP, here we can see the prevalence of pneumoconiosis over time from 1970, and these figures here use data through August of 2021, among working underground coal miners in the US by region. You can see the highest rates are among those long tenured miners working in central Appalachia, and those are the states of Kentucky, Virginia, and West Virginia, and that's located in the center panel. So we can see that after the initial implementation of the Coal Mine Health and Safety Act, cases of pneumoconiosis decrease, but starting in about the early 2000s, we see a resurgence there. And so currently, in 2021, about 20%, or 1 out of every 5 working long tenured coal miner in central Appalachia has X-ray evidence of pneumoconiosis. And this figure also uses data from the CWHSP and shows that nearly 4% of working long tenured coal miners in central Appalachia have complicated black lung or progressive massive fibrosis. This is the most severe and debilitating form of the disease. Other recent studies have identified thousands of additional cases among former coal miners, because of course, CWHSP, we have the legal mandate to screen working miners. Because of this and the voluntary nature of this program, CWHSP likely only sees a sliver of all the disease caused by coal mining. There are clinics in central Appalachia that have identified hundreds of additional cases of PMF that are not reflected in this data of working coal miners. So to understand some more about disease and exposures among coal miners, our group and others have published research using data sources outside of the CWHSP. So a number of studies have suggested silica dust, or quartz, as MSHA refers to it, has played an important role in the resurgence of Black lung in Appalachia. So in 2019, researchers from our group looked at MSHA inspector data. So again, MSHA is the Mine Safety and Health Administration in the US. Looked at MSHA data from the past 35 years and found that the average silica content in Appalachian coal mines has consistently exceeded 5%, which is the level that puts coal mines on a reduced dust standard. And the average silica content in coal mines outside of Appalachia has stayed below 5%. So you can see on this figure here, Appalachia is consistently above that 5% cutoff. We also followed this up by looking at MSHA inspector data at surface mines from the past 35 years and found over 15% of respirable dust samples containing silica exceeded the respirable dust standard. And the mean percent silica in central Appalachia was higher than the rest of the country. So overexposures to respirable dust containing silica have and do occur at not only underground, but US surface coal mines, particularly among miners in drilling and blasting occupations. And here I also want to address some of the research done in other groups. So for example, there's a team from Virginia Tech, recently published work led by Emily Sarver, examining particle sizes and mineral content of coal mine dust from 25 underground coal mines. And they found that samples in central Appalachian mines had more dust associated with the rock strata, which is largely composed of silica and silicates. And that rock represents about 37% of the total mining height in the central Appalachian mines. So I noticed somebody else mentioned in the comments that the reason why we're seeing so much CWP, an increase in CWP, is due to dust coming from above and below the coal seams. Well, the coal seams are getting thinner as well. So yes, we are definitely seeing that. And I'll note here as well that the 37% of the total mining height in central Appalachian mines is rock, and that's compared to 16% in non-central Appalachian mines. So in central Appalachia, they're exposed to much more rock dust. And as Dr. Goldsmith mentioned earlier, there was another study published online just last month by some of our colleagues from NIOSH, analyzing lung pathology from 85 coal miners with progressive massive fibrosis. And that's using data from the National Coal Workers Autopsy Study from NIOSH. So miners born after 1930 were found to have higher concentrations of silica particles compared to older miners. And that further provides evidence for the role of silica dust in the resurgence of Black lung and PMF in US coal miners. And I will also note that among those miners, the majority, over 70%, were from central Appalachia. So these findings really drive home the need for respiratory health surveillance of US coal miners. So yes, respirable crystalline silica dust is playing a role in the resurgence of severe pneumoconiosis in central Appalachia. And effective technologies and best practices do exist for controlling silica and other coal mine dust exposures. Though working as a coal miner is a dusty job, pneumoconiosis itself is preventable. So prevention starts with limiting exposure to coal mine dust through the use of proper engineering controls and close adherence to ventilation plans. So that includes dust curtains, controlling air movement, and the use of water sprays. Miners must also continue to be screened for disease in order to diagnose disease early and prevent progression of disease. So overall, these findings underscore the importance of monitoring and controlling exposure to silica in coal mines and focusing on the health and safety of coal miners. So I'll close out with a quote here from the Federal Coal Mine Health and Safety Act of 1969. The first priority and concern of all in the coal mining industry must be the health and safety of its most precious resource, the miner. Thank you.
Thank you, Dr. Hall. It's very good to have you share with all of us what's going on. So the next up is I'm going to work with Dr. Tsi, Shelley Tsi from China, and I'm going to talk about silica and cancer risk, as she and I are going to very briefly take a look at this, and she's going to talk about some of the outstanding work that she has been involved with in Hong Kong. So as many of you know, or maybe you don't know, but I've been involved in looking at the question about whether silica is a carcinogen for most of my career. And I have very briefly tried to summarize some of the epidemiology evidence, and I'll show you some of the information of relevance after the International Agency for Research on Cancer, known as IARC, evaluated silica as a human carcinogen, which really has only been in place for 20 some years. So we want to look at lung cancer. We want to look at the risk of cancer after silicosis, and some of this has been talked about already. I want to share with you some information about the lung cancer risks from silica exposure amongst non-smokers, and Dr. Tsi is going to talk about the smoking issue. And I also want to talk about women exposed to silica and their risks. So it was mentioned already by Dr. Williams about the 2016, the Department of Labor, the OSHA, had a new rule for silica dust exposure that put into place half of the prior exposure limit. And this needs to be seen in context because the IARC judged evidence that silica was a probable carcinogen, or 2A carcinogen, in 1986. It was revisited in 12 years later in 1997, and then a subsequent 12 years to 2012, that the evidence was sufficient for silica to be a type 1 or a known human carcinogen. In other words, silica dust prior to 1980s was considered not to be carcinogenic, and that has changed since 1997. And we want to think about what has been the evidence since that IARC evaluation. I do want to briefly say that the silica industry in the US challenged this 2016 revised OSHA permissible exposure limit, and there was a court finding that the industry arguments were not going to be accepted by the court. And since 2017, as Dr. Williams has told you, OSHA has been doing regulations with a new standard. So I also want to just briefly say that there are other agencies that have looked at this question about IARC's decision to call it a known human carcinogen. They include California's Prop 65, the National Toxicology Program, NIOSH, the American Thoracic Society, and the European Union. And I have tried to summarize some of this in a chapter that's coming out soon, I am told, about silica and IARC decision. OSHA also recognized that workplace silica exposure was linked with kidney disease, autoimmune disease, and COPD, and lung cancer as well. And these are pretty drastic changes for OSHA as an agency, but this is something that we need to keep in mind as well. I do want to share with you a little bit of epidemiology data, first starting off with this strong paper that was done by Steenland and colleagues in 2001. They worked, and IARC brought together a pooled 10 cohort studies with nearly 1,000 deaths of high quality sampling data and mortality follow-up from several different silica exposed populations: diatomaceous earth workers, granite workers, industrial sand, gold workers, Finnish granite, Chinese tin, Australian gold miners, and South African gold miners. And what Steenland showed was that a categorical analysis shows that the odds ratio by exposure quintiles takes a little bit of time, but once it gets to the third quintile, the risk is 1.3, goes up to 1.5, and at the highest exposure quintile is 1.6. And this also is very much worth sharing. It doesn't appear that the risk really rises very much with this lag of 15 years built in, but after 7 or 8 years, the risk goes up quite a bit. And the log rate ratio, which is what's on the far left-hand side, rises dramatically. So it doesn't really show much, but once a miner or a silica exposed worker has completed 7 or 8 years, their risk of lung cancer goes up quite a bit. So this is a study from Cassidy, a multi-centered case control study of silica and lung cancer, and they showed an odds ratio of 2.1, which isn't statistically significant for females, but for males, a risk of 1.3, which is significant. Never smokers have a risk of 1.4, ex-smokers 1.3, and current smokers 1.4. In addition to that, the group of investigators in Cassidy looked at the risk by cumulative exposure, and the risk rises quite dramatically, so that the cumulative risk from 15 to 200 milligrams per cubic meter produces an odds ratio of 1.4, and above 200 milligrams per cubic meter, 2.08, which is for trend highly statistically significant. Oh, I think I skipped one. There's a work done by Ziad on co-workers, studied silica among Hong Kong non-smokers. They had 132 cases and 536 non-smoking controls, and the odds ratio for silica was 2.58. When they looked at adenocarcinoma, the adjusted odds ratio is 2.9, which I found to be a very interesting finding. We can come back to that in the roundtable. There are other cancer follow-up studies of silicosis patients, and the earliest ones were done by Murray Finkelstein in Canada and Peter Westerholm in Sweden in 1980 and 1982. There are several meta-analyses showing an approximate doubling of lung cancer for workers with silicosis. And there have been other epidemiology evidence for elevated cancer risk for skin, lymphatic, GI, including esophageal cancers and kidney cancers. And nephritis and kidney disease has also been linked with silica dust exposure and with silicosis as well. Just a bit of a mention, two papers that I found. Tomas Skova from the Czech Republic looked at co-workers pneumoconiosis patients, and they found an SMR for lung cancer of 1.7, non-malignant respiratory disease 2.78. These are both statistically significant. Hung et al. Conducted an incidence study in Taiwan and found several cancers. All cancer had a slightly elevated risk of 1.12, esophagus 1.76, stomach S 1.42, liver 1.18, and the lung is 1.45. In other words, in this study of co-workers pneumoconiosis patients, there are several elevated standardized incidence ratios reported in this. And this also suggests to me that we should be doing other studies of cancer amongst workers with CWP and silicosis. And there's one other paper I'm very keen to share with you, a paper by Liu et al., who had studied 34,000 Chinese workers, tungsten, iron, and ceramic workers, 11,000 plus deaths, and 546 lung cancers. There was a very strong gradient for those with silicosis, but the authors did something I found to be very interesting. They excluded 427 silicosis cases among the lung cancer and then reanalyzed the risk of 119, and they found there was a dose response for this group of non-silicosis, and the risk goes from 1 to 1.12 to 1.41 up to 1.7. So this study, if you will, negates the argument that silicosis is necessary for lung cancer, as has been argued and postulated by people in the silica industry, at least in the United States. So if you look at the current evidence, IARC's ranking of silica dust in 97 and 2012 has been backed up by studies confirming the lung cancer risk, including studies of women and non-smokers. There is a strong and consistent evidence of silicosis patients having more than a twofold risk for pulmonary cancer, with additional findings of GI and kidney cancers as well. So in conclusion, we know that patients with CWP and silicosis and some other cancers, that we need more studies, frankly, especially of co-workers' pneumoconiosis, as there appears to be a lack of a clear elevated risk. We need additional morbidity and mortality studies of countertop workers and railroad workers focusing on disease and exposure links. And we need to ask a question, which I hope we might get a chance to look at on the roundtable. Are there pathology differences between lung tumors among silicotics or silica exposed workers compared to what I call garden variety of lung cancers? Is there some way to distinguish on the pathology side the differences between them? And we need to ask agencies like OSHA, MSHA, and NIOSH in the US, and agencies in China and in India and in Australia to encourage studies, to encourage prevention activities, because we need to get our corporate leaders involved in this, as well as having this be a concern of the academic community. So I want to stop here and turn the presentation over to Dr. Tsi. Shelley, if you're on mute.
Can you hear me?
Yes, but you need to speak up a little bit.
Yeah. Okay. So good morning here. Thanks, Dr. David Goldsmith, for your kind invitation, for an opportunity for a talk this morning. So I'm going to share with you a topic about effects of smoking and smoking cessation on all cause, all cancer and lung cancer mortality among a cohort of 4,418 silicotics in Hong Kong, and the follow-up period from 1981 to 2019. So I'm Shelley there, a professor from Jockey Club School of Public Health and Primary Care, the Chinese University of Hong Kong. So lung cancer actually remains a leading leather cancer worldwide. So in Hong Kong general male population, lung cancer account for 30.7% of all cancer deaths. Because I emphasize male because in Hong Kong, the majority of silicosis cases actually, they are males. And then I check with the US males and the female gender population. And then lung cancer actually among males accounts for 21.3% of all cancer deaths in US, according to the most updated data from website. So lung cancer actually is also the major cancer cause for workers exposed to silica dust, particularly for those suffering from silicosis. So in Hong Kong silicotic worker cohort from an earlier follow-up from 1981 to 1999, lung cancer accounted for 46% of all cancer deaths among silicotic cohorts. And in Australia, I checked from literature, and then from the cohort, and then the lung cancer can account for 44% of all cancer deaths. So, which the difference between the lung cancer structures between a general population and the silicosis cohort indicate that the difference is probably attributable to silica itself or smoking. A meta-analysis by pulling 27 cohort study of silicosis and lung cancer by searching the period from 1966 to 2004, so demonstrate a combined SMR of 2.45 with a significant 95% confidence interval, but it reduced greatly to 1.6, but the confidence was still significant after smoking was indirectly adjusted. So which indicate that tobacco smoking has contributed to a large etiological fraction of lung cancer among workers with silicosis. So we further follow up our cohort from 1999 for 6 more years, and then further recruit, 2.29, and the further follow up until 2014, and then we published the paper in British Journal of Cancer. And then you can see that there is a downward exposure response relationship between using smoking cessation and the lung cancer mortality among more than 3,000 Hong Kong silicosis workers. So there is actually some still research gaps, evidence is looking about the association between smoking and the smoking cessation, the risk of mortality from all cause, all cancer and cancer other than lung cancer actually among workers with silicosis. So I'm going to actually from this project going to rectify this knowledge gap using a tetra-wide based new cohort, actually most updated cohort among 4,418 silicosis workers during 1981 to 2019, and to follow up still like end of 2019. So this is the some basic characteristics of 4,481 silicosis workers by according to the category of smoking status at a baseline. So you can see that I highlight with the red highlight here, say the current smoking, the age at diagnosis seems a little bit younger than the never smoker and former smoker, and the age at death actually relatively younger, earlier than the other 2 categories. And then compare with the larger opacities between these 3 groups. And then you can see that for the former smokers, the percentage of larger opacity is slightly higher. And then we compare with the, say, cumulative dust exposure, cumulative silica dust exposure with a milligram per cubic meter years. And then never smoker looks like a little bit slightly more a high exposure than the former smoker and the current smoker. So I further calculate the number of lung cancer among never, former, and current smoker, so that you can see that only 6 in never smoker, but more in current smokers. So the other cancers in our cohort actually is because due to cancer are digestive cancer, just like David said, digestive cancer, which account for like 30% around, and then head and neck, and others like lymphoid and hematopia related tissues. So I'm going to compare with the say those response relationship about the smoking, say years of smoking and past year and smoking status among say 4 different outcomes, like all causes of death, all cancer, lung cancer, and other cancers. So you can see that there is consistent dose response relationship with all these outcomes, but the dose response actually the relationship more prominent for lung cancer. So you can see the dose response here, the slope actually is quite steeper than the other outcomes. But for the other cancers, you can see many of the categories becomes not significant. So it means that the dose response observed among all cancers actually is mainly attributable to lung cancer. And then in terms of smoking cessation, so you can see that with the among current smokers, actually among ever smokers, we compare different years of cessation and using the current smoking as the reference group. So you can see that for all causes which actually have a negative gradient with years of cessation, and then for all cancers, also you can see a negative gradient, and then for lung cancer, the negative gradient even stronger. So when we further collect the data about the smoking status, the change of smoking status during follow-up, and then we defined the never smoker, the people before diagnosis and after diagnosis, they keeping non-smoking status, and the persistent quitters that at the baseline diagnosis of silicosis, they are quit already, and then during the follow-up, they can keeping quitting status, and a never quitter means that keeping smoking always. And a new quitters actually means that at a baseline they are current smoker, but during the follow-up they change to change to status as former. So we define this as new quitter, and never quitter means that they never stop smoking. So you can see that there are some benefits for persistent quitters, particularly for lung cancer. You can see compare with new quitters and persistent quitters. So you can see there are still some additional benefits from these persistent quitters. So which indicate keeping smoking, quitting, which actually is good for silicosis patients. So this is some further analysis about for those never smokers, persistent quitter, new quitter, and a never quitter. And then we are stratified by smoke opacity, large opacity, and different exposure level of silica dust, and if they have a history of tuberculosis. And then you can see that there are some additional benefits for among persistent smokers in if they are actually if they are the small opacity, and if they are actually have a high silica dust exposure. So this is actually some effect for lung cancer. And for the other cancers, additional benefits from the persistent quitters actually is not very clear. So in summary, this a study among 4,481 silicosis workers followed from 1981 to 2019 demonstrate that smoking cessation has substantial benefits to reduce all cause, all cancer mortality, while the reduction of all cancer mortality was mainly attributable to lung cancer. So the new evidence actually is generated from this study that persistent quitters have more benefits on all causes and lung cancer mortality than that of the new quitters. A downward dose response relationship with years of smoking cessation underscores the importance of occupational health practice to promote workers from smoking and develop effective control measures in helping particularly the obstinate smokers quit smoking. So this project actually is ongoing project. We got the funding from Pneumoconiosis Compensation Fund Board of Hong Kong, and then we have team of my PhD student and doctors from tuberculosis chest service pneumoconiosis clinic of Department of Health in Hong Kong government. So thank you very much for invitation. Thanks.
Thank you, Shelley, very much. Our next set of presenters include Victoria Arundale and Frank Hurrell.
So thanks everyone, and thank you to the organizers for the invitation today. Nice to see so many familiar names and faces. I'm Victoria Arundale. I'm based at the Dal Lana School of Public Health at the University of Toronto in Ontario, Canada. So I guess I'll just start with a little bit about where I am. I think most people know Canada. We're a big country, not as many people as you might think, and we're split into 10 provinces and 3 territories. And in fact, for most of workers in Canada, health and safety is a provincial responsibility. So we don't have a nationally harmonized system for health and safety. And what that means is that we get patchwork and a lot of variability among some of the regulations. And Silica is a good example of this. So I've modified this from the Carex Canada profile that's available online, but you can see that some provinces, including our federally regulated workers, are subject to an OEL that is the same as the ACGIH TLV. But in other cases, it's the same as the new OSHA PEL. And where I am in Ontario, we are still at 0.1 milligram per meter cubed, or 100 micrograms per meter cubed, so 4 times higher than what the ACGH recommends. And in terms of other regulations that we have, so in the province of Ontario where I am, we do have medical screening or medical surveillance requirements. Silica is a designated substance here in Ontario with additional regulations above and beyond the OELs, and it specifies the use of things like chest x-rays and pulmonary function testing at different time points. So you're allowed to do pre-placement exams here. You're not allowed to do pre-employment exams. So once you've hired someone, you can initiate the medical surveillance procedures before placing them in a position, and then you would do them periodically and upon exiting if they have had more than 10 years of exposure, unless the most recent exam was performed within the last 12 months. And an interesting exemption to this, which I'll come back to sort of in the last slide, is that this doesn't actually apply to the construction industry in our province. The construction industry has had several exemptions over time that have sort of slowly been whittled away. But this is one that persists. Carex Canada, which I mentioned earlier, is a carcinogen exposure surveillance project that's based in British Columbia in the western part of the country. And they have used existing exposure databases as well as information from the census to estimate the prevalence and level of exposure to a variety of carcinogens, but one of them is silica. And what this is showing here really is that in Canada, we think that most of the silica exposure is happening in construction, different sectors within that. So the larger the circle, the more people are exposed in that group, and the darker the color, that represents higher levels of exposure. So you can see the distribution across low, medium, and high does differ. And of course, in mining, we see again lots of high exposure there. A group that I was part of that was led by Paul Demers here at the Occupational Cancer Research Centre in Toronto used those estimates from Carex Canada to estimate the burden of lung cancer resulting from silica exposure at work across the country. And the resulting estimate was that annually silica exposure is estimated to cause about 550 cancers among men and 25 cancers among women. These numbers were derived by using the attributable fraction overlaid with our national cancer statistics. And where I am in Ontario, mining continues to be big business, and there's a long history of mining in the province of Ontario. And this is where historically, probably we thought the most about silica. This is a map from last year showing all of the mines that are still active, and they're largely gold mines with some base metals in the northern part of the province, and then salt mines and quarries in the southern part of the province. So we have looked at silica exposure historically in the province of Ontario in mining using existing exposure databases. And this is from a publication from last year by Nicola Blagrove Hall, who's now a PhD student in the Netherlands. And we were able to look at historical data. So I'll tell you what we took away from this graph. So the average geometric mean for the silica levels is shown on the right-hand y-axis. The solid line is surface measurements and the dotted line is the underground measurements. So we did, when we modeled this data, see a slight decreasing trend over time, but it's not as striking perhaps as I would have expected. And also the surface levels that we observed were equal and in some years higher than the underground measures. So we did see a significant potential for silica overexposure in surface miners or surface workers, as well as the underground miners. This red line is approximately, actually it's a bit high in fact, where the ACGIH limit would be. And I would just, it's to pick up on something in one of the earlier talks, there is work from Dave Verma, who sadly passed away recently, but looking at the silica content in the ores being mined in Ontario, and it does vary quite a bit depending on the location and the ore being mined. So it's something to keep in mind just when we're thinking about the content, the silica content, and how that might vary from mine to mine. More recently, as many folks have talked about tonight, there has been concern about artificial stone and its use specifically relating to countertops. We have had cases of silicosis in Ontario that clinicians have linked or believe to be due to work with artificial stone. I double checked today, there's no papers yet, but I suspect that folks are working on those. It has led our Ministry of Labor Training and Skills Development to issue a hazard alert about silica exposure during these manufacturing and installing procedures. Our provincial occupational health and safety system partners have updated some of their resources and documentation to support employers. And as Dr. Gorman-Ing talked about earlier, there is a program to expand the use of that silica control tool from British Columbia into Ontario in partnership with the occupational health clinics for Ontario workers. So certainly a lot of focus on silica, not just in mining anymore here in Ontario. And what this concern, particularly around the potential for new exposures in emerging industries, led us to do was to look at our administrative health data. So we do have a near universal healthcare system here that's largely single payer. And we're able to pull the billing records by ICD code for the whole province. And so we looked at the rates of silicosis cases over about a 20-year period. And what we saw was fairly low rates of silicosis using this billing data, higher levels among men with a decreasing trend over time, which is at the population level consistent with some other jurisdictions. We did compare to asbestosis and pulmonary fibrosis just to look at similar diseases. For asbestosis, we see higher rates, but similar trends in terms of men and a decrease over time. But we see an opposite trend with pulmonary fibrosis. This is a very general ICD code here that includes many different diagnoses. And it did tend to increase the rate of pulmonary fibrosis. Billing records did increase over time. And we have some hypotheses about how incentives for billing under certain codes may have interfered with this particular outcome, but we're continuing to do some work here. This is fairly new results. They'll be presented at the American Thoracic Society next month and hopefully submitted later this year. So Just to wrap up and try and stay on time, the view from Ontario, we do have anecdotal reports of silicosis among workers that are handling and manufacturing artificial stone. This is classified as manufacturing and construction in Ontario, depending on the company. But we don't see any noticeable upward trend in silicosis at the population level, although, I think there's a lot of concern remaining. We want to revisit this and continue to watch it, and also, further investigate some of the data questions that we have. And, we continue to have concerns about lung cancer among these workers, not just silicosis. But there are certainly many opportunities for improving the prevention of silica exposure here in Ontario. I think we don't have recent data. I think I failed to mention that in my mining data slide, that our data in Ontario from the government perspective really does end in the mid-90s, and we have a real gap in terms of knowing what current exposures are like in mining and construction in all workplaces. I think there continues to be a need for increased awareness of silica as a hazard, especially in these manufacturing workplaces where perhaps it's a newer exposure for them. There's definitely opportunities for improved enforcement of the regulations that we have in place currently, and that would include medical surveillance. We certainly don't think that there's great compliance with the medical surveillance requirement, and an expansion to include construction, although challenging, would be very helpful. And there is a need, especially in Ontario, to update our OELs to use more of a health-based approach. Our Ministry of Labour Training and Skills Development has initiated this. They have done a public consultation on a lower silica OEL, but it has not yet been adopted. And we're in an election year here, so it's unlikely to move imminently, but hopefully it will soon. And that's all I have, so thank you.
So thank you, all of you, for your presentations. My apologies, we've gone over a little bit, but we do have a presentation from Frank Hurl to talk about the situation and health risks and policies in the U.S. Go ahead, Frank.
Thank you very much, and Victoria, thanks for covering the policy issues regarding Canada. And I'm going to give you a quick look at policies in the United States. And are my slides coming across okay?
Yes, they are, Frank. Good.
Okay, great. So, first, I think I want to repeat a little bit from what Dr. Williams gave us earlier in the US as far as OSHA standards. OSHA updated its standards in 2016, setting up an action level at 25 micrograms of silica per cubic meter of air with a permissible exposure limit of 50, and specifying exams with x-rays for every 3 years if a worker is determined to need a respirator for more than 30 days per year. Medical surveillance also required if for 30 days a year they could be over the PEL. And it all became effective on June 23rd, 2018. Construction workers, they took a different tack. They must meet a standard or comply with Table 1, as was described. And I'm going to kind of touch on things from the NIOSH perspective as to how we've been dealing with Table 1. But before I do that, I want to let you know that the Mine Safety and Health Administration is in process of changing their standards. But in fact, in mining, the standard is still for metal and non-metal mines, 10% quartz plus 2, the formula that reduces the exposure to respirable dust. So they have not done the rulemaking yet to harmonize with the OSHA standards. And in coal mining, things are even a little bit more different, but I won't go there. Construction Table 1 looks like this. This is just one example. It describes what engineering controls are required. And if you follow the engineering controls, you don't have to do exposure monitoring. It becomes assumed that in fact you are meeting the exposure standard. So where does NIOSH fit in this policy thing? Well, one of the things is we've started a series of studies to look at the various engineering controls that are possible for different types of exposure situations. So we talked. Bob Harrison talked about stone countertop methods and so forth. And while we were looking at that, there's some cases where even if the tool provides a water spray, it may not be effective if the cutting edge isn't where the spray is coming out, as was seen in that one. So you have effective, but on this side, ineffective and effective, depending on how it's being used. So NIOSH is doing a little bit of studying on that. We're looking at issues related to power chisels with the local exhaust ventilation, or a power saw with reciprocating blades, and using it with a 3D printed optimized on-tool hood to try to capture the dust as another possible control technology. These are covered in reports that we've got online, and I've got them linked on this slide, and my slides can be made available to everyone. So you'll be able to go back and check out those reports. In 2019, before the pandemic, OSHA reached out to NIOSH and asked us to evaluate the exposures related to the Silica Standard Table 1 for construction industry. And we began carrying out evaluations to validate and augment Table 1 tasks. So I know someone asked us, is there going to be an update for Table 1? We were trying to work on, we were working on developing data that could be used for that regulatory process. Of course, the pandemic put a stop to our work. I think once everyone gets back to it, we'll probably be back on the trail of looking at the engineering controls for construction. And here linked are the 3 of the completed evaluations that were done during dowel drilling, drywall sanding, and micro trenching operations. There are completed HHEs that are available online. Again, these are all live links that you can get to, which you can see from my presentation. And there's a couple of pictures of dowel drilling with water controls. Exposure measurement research. One of the other areas that we've been active in at NIOSH is looking at ways of being able to get the results of the silica sampling more directly. You know, the usual technique is you hang a personal sampling pump on somebody, or you set out area samplers, and then you send a filter sample back to the lab, and then maybe a week or 2 later, you get the results. Well, this is not quite as happy as if you're being able to get the result on the same day you collected the sample. And so NIOSH developed a program of FAST software that interacts with a Fourier transform infrared spectrometry that allows one to actually be able to process the sample on site at the end of the shift and come up with a evaluation of dust level. Someone asked, is this capable of being used for compliance? I don't think it is. I think it still requires that you know, a formal sample be collected, sent to the laboratory that's a accredited laboratory, and comes back with a result that would give you a result that would stand up in court. However, if you're interested in dust control, and that's the main reason I hope we're all here, then getting a reading of the same day that you have it, especially on a very changeable workplace like a mine or a construction site where things are changing constantly, will allow you to take actions and do dust control on the spot based on the most current data. And of course, we're also looking at software. I have put this up at Helmet Cam and Evade software that uses simple dust monitoring equipment to kind of track continuous monitoring of dust levels in the environment. For crystalline silica, that's not yet possible. And I just want to put another limitation on the FTIR technique. It's generally limited to being effective in coal mines because there's competing minerals that would interfere with the FTIR signal that make it a little bit less useful if you're not dealing in coal, if you're in, say, you know, metal and non-metal mine, or maybe even some other construction site where there's clay dusts and other sorts of interferences available, where X-ray diffraction is generally used. But the real option here, or the goal would be to try to develop something that gives you an instant feedback on the exposure levels and allows your hygiene staff, your engineering staff to put in controls in real time. And that would be the optimum way to protect workers. So the summary is the silica standards are set by OSHA. They have standards for general industry, maritime, and construction, including the Table 1 option. And NIOSH research, we're working on trying to augment Table 1, validate aspects of Table 1, and also then trying to improve the sampling and analysis technique so that you get a more rapid feedback that connects what you're seeing in terms of results to what's actually going on in the workplace, and allowing actual feedback. Of course, there's the standard set of disclaimers, and thank you very much.
Thank everybody. Thank you very, very much for all of your presentations. I apologize. We have sort of gone over time. I would like to try and get some questions in, and I'd also like to add a colleague who joined the Zoom who said he couldn't make it, but he's here. His name is Dr. Jerry Abraham, who's a very well known pathologist and has been involved in that study I talked about earlier that Cohen was the first author on. So can I ask, if you will, Dr. Abraham, Dr. Hoy, Dr. Eng, Melanie Eng, and Bob Harrison to sort of be our roundtable participants. And I would like to start. I've got questions in the chat that I'll try and get to, but I want to ask Dr. Abraham a quick question. Sort of was in my presentation. Is there any evidence that lung cancers, lung tumors that arise from cases of silicosis or co-workers pneumoconiosis, for that matter, differ somehow from garden variety lung tumors, many of which are linked to tobacco smoking? Is there any way that is a possible fruitful avenue for research in this area? Dr. Abraham, you got to unmute.
I didn't know it would let me unmute. Thank you so much, David.
Sorry.
I'm glad I was able to participate. I should mention that two of the other pathologists who were involved in that study on coal workers are on this call. Dr. Murray from South Africa and Dr. Franco from Alberta, Canada, or at least they were both on this call earlier. So there's three pathologists that I know of on here. And one of the points I would make is that pathologists are usually left out of most epidemiologic studies. Sometimes they come in as an afterthought. So for those of you doing epidemiologic studies, I would just make a plug for you to find some pathologists in your group and get them involved, because a little bit of pathology can go a long way in answering some of these questions that are not resolved by levels of gray and x-rays and things like that. With that out of the way, to answer your question, I think it's going to be the need for further research if someone wants to do it. As you probably know, with the issue of asbestos exposure in lung cancer, the original studies suggested there were some differences in location with asbestos exposure. And the consensus now, as far as I'm aware, is that there is no real recognizable difference in histologic types of lung cancer. There's investigations looking for certain mutations that may be used in litigation to confirm or deny compensation to somebody with a lung cancer with asbestos exposure. That's my personal interpretation of that right now. I'm not sure what research is being done with silica and lung cancer. I'd be interested, David, if you or others would comment on the question of whether the argument about do you need silicosis or just silica exposure to have silica-related lung cancer, as has been a big area of discussion with asbestos and lung cancer. How is the progress on that issue in silica?
I'm going to briefly say that I don't think there's been much progress in that regard. That was something that was part of the industry filing after the 2016 OSHA revised standard came on. Their argument was that OSHA could not label silica as a carcinogen because the only time that was true was that when you had, epidemiologically, when you had cases of silicosis, and that was the only time that lung cancer showed up. The study by Liu et al. That I made reference to, I think put a stop to that argument, but I don't honestly know on the litigation side, because I haven't been involved in any silica litigation recently, even though I think it's a very serious issue. But I would ask others on the call who might know this, if they would possibly put their answers into the chat for the moment. I did have one other question for Shelley. You basically, I think, are saying that for the Chinese workers that you've studied in Hong Kong, that it's important for looking at the question about the risk of lung cancer to also look at trying to get these workers to stop smoking. Have we interpreted that right? And do you have any successful programs to get those with pneumoconiosis or silicosis to get into quit programs, and do they have a long-standing benefit?
David, actually, we do not have effective program, or even we do not have a smoking cessation program specifically to pneumoconiosis patients. So, yes, we have a pneumoconiosis compensation fund will actually every year provide research fundings for to support us to do research. So yeah, this is an opportunity. We can design some program to get funding to do, yes, some RCT, something like that. Thank you.
Very good. Dr. Harrison, please.
David, this is a question for you that I posed in the chat earlier. Why do you think that we don't consider silica like asbestos? I mean, the epidemiological data that you and others present is so compelling. It's an IR class 1 carcinogen, but it's not treated like asbestos.
Well, I think there are two reasons for that, if I may just say. One is that the risks for asbestos-related malignancies were so high, especially for mesothelioma. They were extraordinarily high. What we're talking about for silica exposure and cancers are lower, in the range of 2 to 3 or 4. What is known is that silica exposure is much, much more common than asbestos exposure. And that's one of the reasons I think that people have tended to not treat it as seriously. In other words, it's such a common type of thing in construction and mining that people in industry, people in labor don't feel as if this is as much of a compelling exposure issue as asbestos has been. Now, I'm certain that everybody who's on the call today could probably give their own answer, but I think that you've posed a really good question, both in terms of focus as well as ethics. I mean, the number of silica workers is just astronomically high, and will continue to be high as long as there are people who don't wear dual face respirators when they work with these products. And we are seeing with the work that you're doing on the countertops, how dreadful the outcomes have been when people have been really blasé about controlling the dust. And you know, we have not seen, I think, the full spectrum or the severity. You talked about those two brothers, both of whom died, sounded like they weren't even 45 years old. When is it that that's going to matter to the degree that it needs to move us off of the dime? And I would certainly welcome a further discussion of that, because it's clear that we need to be placing a higher priority than we have been.
Hey, I just say one quick thing, David.
Absolutely.
it may be my cynical too many years of being involved in this, but what seemed to drive the regulation of asbestos was litigation. So I think a few well-placed litigation cases with silica might push the regulations somewhat, but I don't know. As Dr. Grant pointed out, it's so much more prevalent in exposure worldwide than asbestos, for example.
Yeah, and I do think there was some, I guess 15 or 20 years ago, this terrible decision from this judge in Texas who basically found that there was a law firm who was doing some terrible mixing and matching, taking some screening of asbestos workers, and then turning that same thing and saying, oh, we're doing screening for silica. And that, I think, set back a great deal that potentially might have moved this into that direction. But that's within the US. The question is what's going on in places like Australia and South Africa. South Africa has just gone through some pretty serious litigation, and there's much more attention being paid to African miners than there was just 5 or 10 years ago because of that litigation. So that really, what you're saying is true. Nevertheless, it's still, as Bob Harrison points out, it isn't placed in such a high profile. The other issue in the States has to do with the countertop workers being, many of them are immigrants, Spanish-speaking immigrant workers. And what we know is that once they have a diagnosis, they tend to move back to their countries and die. And they're not involved in litigation, they're not involved in follow-up reasons. So that, I think, is part of the reason that we've got that situation. Please, Marianne, go ahead and ask your question. I see you put it in the chat, but I'm not quick enough to pick it up before I lose it.
No, I didn't have a question in the chat. I was actually repeating someone else's, but since you called on me, I will say something. Thank you. For one thing, I want to thank you, and Kevin, you did an amazing job in bringing everybody together. This is just incredible. And I do want to thank everybody who's here at all hours from wherever they are. Perry Gottesfeld put something in the chat. I asked him if he wanted to unmute, so do Perry, if you can. I know he's done work about the engineered stone and a lot of work on silica and tuberculosis in India, in Africa. And it seems to me that there is an opportunity to really address this countertop issue all along the supply chain. I mean, we're familiar with it here because of people actually installing countertops, when and the kind of things that Dr. Harrison has talked about. But think about the people who are actually making that engineered stone or cutting the granite and then shipping it to the developed countries. There have been opportunities to address things like that have a very lengthy supply chain and an opportunity to influence that at the consumer level. Certainly that's happened in the fashion industry, in the jewelry industry. So I would be kind of interested in people's thoughts about whether there's that kind of opportunity in this case, because the degree of exposure is just mind-boggling. And I think when people learn about, when they get their counter, and I have engineered stone countertops myself, and when you learn about the exposure, there's just a huge amount of guilt that you want to address as a consumer. So I'm just wondering what people think about that.
So I'm going to ask the folks on the roundtable to chime in. Melanie, if you're still with us, or Ryan, we'd love to have your assessments of things from your perspective.
Yeah, thanks.
Unfortunately, Melanie had to go, David. So sorry, Ryan. Over to you.
Understood.
That's right. It's so complicated, I think, in my mind, the horse has kind of bolted a bit in terms of this material getting out there and being so widespread in its use, in terms of the government being able to ban it at this point. Would love to see it being banned, but I think there's a lot more that we need to do in terms of that consumer awareness component. I think I put in the chat an example with the Deadly Genes project around the Turkish sand blasting denim jeans.
Right.
And I think that was really pivotal in terms of making a change in that industry. I think really it is going to come back to consumers being aware of it. Amongst my, my colleagues here, all the other doctors I know, when they're going out to select a new bench top for their kitchen, it's a difficult discussion because often there's not a good alternative for them, and they're challenged by the designer or the architect about what to actually put in, really pushing them putting in an artificial stone material. So I think we need much more consumer awareness about it. And, I think, this group is a good way to do that, but there's a lot of other avenues that we need to do that through too.
Yeah.
And sorry, I should just say as well, the change here in Australia came after patients, workers telling their story. It really required workers to actually put a face to how bad this actually is, to then lead to unions getting on board, governments getting on board, and then action actually happening. Graham Edwards is on the call as well from Australia, and we had quite a few years of advocacy work which went nowhere. Even though we had evidence, we went to government ministers and nothing happened until the media really became interested in this problem.
Yeah, and I would just like to throw in, the fact that, this was not something that was confined to one country. It was everywhere. So the other thing that occurs to me is that technologically, there isn't really, a high-tech fix. We just need to use and get the manufacturers to really invest in wet methods, and they should be able to protect their workers very well with that. Is that not the case?
I don't think so. I think first and foremost, this is a highly hazardous material, and I think it needs to be thought of that way. I think with the example of asbestos, it's actually a pretty good one for this, because when you're dealing with a material that's 90% silica, there's extraordinarily high risk related to it, and you need to have every single day extremely effective engineering controls to actually mitigate that risk. And most of these businesses are micro businesses with 3 to 5 employees. They just don't have the financial capability of actually having those control measures. And this is where the licensing scheme, may well help some of this, where only businesses that actually have those technologies can actually use this hazardous material. We'll put in the chat also just some details about what's actually coming into to effect here in Victoria, and may come into effect throughout Australia as well in terms of that.
If I can just add to that too, David, wet methods don't always work.
Kevin, move your screen so that we can see your face.
So wet methods don't always work. There's been a lot of useful studies out of the UK to show that, you could still be exposed using wet methods. So, containment would probably be the control, and that can those small, small enterprises afford that? So I really, I can't see any other way around it than banning it. And, I'm just also, if I just want to add, I think maybe a future session, maybe in a year, we could run a session on prevention and control. This has been a really good session on hazard awareness, through health surveillance and epidemiology. But I really think in future, we really need to home in on prevention and control, if I can add something there. Thank you.
Yeah, I mean, that just goes without saying that ultimately everything that we're working on and that we're concerned about has to lead to improved health, to control the dust so that the workers are no longer at risk. And it's the same sort of thing like with concern about silica and fracking sand, silica issues in museums, silica issues in small-scale gold mining. We don't know anything about the children's exposure to mutual exposure to dust and mercury, for example. What is it doing to their CNS, to their central nervous system? What is it doing to their pulmonary health? These are the kinds of things that I think need to continue to motivate us. But you're right. That's Kevin. That's exactly what we need to do. Is we need to talk about some of those success stories in a realistic way. What I think is going to happen is that if we ban these artificial stone things in the developed countries, they're just going to push off to places where there's no regulation, and you'll get the same things produced in places like Vietnam and Indonesia and the Philippines and imported into Canada and Australia and the US. I might be wrong about that, but that's what I've seen happen in other contexts. So
I think we should just thank everybody.
I do
A lot
too.
of people have left, and for those speakers that are still here, I just think we should really thank everybody for donating their time. And we're a volunteer group, and we put a lot of time and effort into this. But for those of you who are guests here, please join. And don't have to commit a lot of time on what's going on. We're just finding out on we need to know what's going on locally, and especially those of you from Africa and Asia, and not the kind of more developed economies. And so please join. Please join. That's all I have to say. Thanks.
Can I just say something too about joining? I just want to point out that Workplace Health Without Borders, all the branches, have been quite successful when we start committees to deal with specific issues. Examples are, Alec talked about the asbestos committee, we have a waste workers committee, we have a brick kilns committee, we have a nail salons committee. These committees meet more often than we can have these webinars, and they grapple with specific issues, get together, apply for grants, collaborate on research, collaborate on awareness building. They really can do an awful lot. The brick kiln committee, for example, is partnered with a group that has done a lot of work on the supply chain for a brick manufacturer in Nepal. So if anybody here is interested in doing that kind of thing on some of the issues we've talked about today, be it countertops all along the supply chain or silica in construction, the brick kilns have addressed silica in brick manufacture. Please do just let us know. I think you have the email from the notice that was sent out, or put your email in the chat if you want to do that right now, because we would be really interested in helping anybody who wants to start such a group.
And I see Syed Fazal just thanked us. He's a Canadian engineer, so this is new to him. So if there's people out there that are engineers, we're not exclusive. We're looking for we're looking for people that can help provide solutions as well.
Let me just say one final thing, just very briefly. We've also tried to develop student chapters at universities. And I must say, personally, that has been very rewarding. It's also been a positive source to get younger people, young students involved in workplace health and safety issues. And I would strongly recommend this as a good idea for people who are interested in replicating this. And please send me an email, and I'll be happy to share with you what I know about WHWB's university chapters and things like that. But let me echo what Kevin just said. Thank everybody, Marianne, Ryan, all of those who stayed on the call, Bob Harrison, all of you, Jerry Abraham, many of you have joined us. Dr. Tse, it was very nice to meet you and to work with you, even though you're in Hong Kong and we're not. We look forward to opportunities for collaboration in the future. And again, Kevin, thank you for your good nature and your excellent advice. And it's really been a pleasure to work with this. Thank you, Noemi Hall and Frank Hurl, those of my colleagues who volunteered. I am extremely grateful for all of your work. Have a nice evening, if that's where you are, or morning, if that's where you're coming from. And we look forward to hearing back from you in the future. Again, thank you, one and all.